Friends, today's ULCER story is about a welder's burn, which was not healing. Let's see why. A young male who was an ITI student was referred to us. He had irritation and visual loss in right eye 16 days ago when he did some welding work at his institute. Next day he went to an ophthalmologist who noted that there was a large central epithelial defect, and for this he was started on frequent lubricants and moxifloxacin 4 times a day. In 3 days, decrease in defect was noted, mild steroids were added, and he was asked to come after a week. At this visit, however, they found that defect has not healed further and they suspected infection. His antibiotics were changed from moxi to Getty and steroids were stopped. But his current drug regime was very different from his prescription. He was using moxi, Getty and lubricants 4 times a day. On examination, his vision in right eye was counting finger 1 meter, IOP was normal digitally, bulbar conjunctiva was mildly congested, but upper tarsal was severely congested. There was no discharge. Cornea had a 3 by 4 mm epithelial defect with diffuse haze. Edges of defect were slightly raised and smooth as we see in persistent epithelial defect. Bare stroma had a greyish-white hue and not the yellowish-white appearance of infiltrate. This haze extended beyond the defect margins. There were few filaments also. Other eye also had mild bulbar congestion but diffuse upper tarsal congestion. So we were dealing with a non-healing epithelial defect post-welding exposure. All of us have seen welder's burn, also called ultraviolet keratitis. They are just corneal erosions which typically cause pain after 8 hours and heal within a day even if we don't give any medication. But this patient has not healed, rather landed in persistent epithelial defect. So I started asking about and looking for any ocular and systemic pathology which can retard epithelial healing. He denied any systemic disease, but when I asked about dry mouth, he replied positively. On asking, he told that he was having gritty feeling in both eyes since long. I checked Schirmer in other eye as due to the defect right eye test could not be accurate and the Schirmer in left eye was only 3 mm. He was started on hourly lubricating drops, nighttime gel and prophylactic antibiotics. In other eye 2 hourly lubricants was advised. In view of dry mouth and dry eye, I suspected Sjogren's syndrome and certain blood tests were advised. But patient and his parents were reluctant on that day. On follow-up after 3 days, his defect was just a linear streak. Now they were willing for tests too. So blood tests for SSA, SSB antibodies were advised. When he came after 1 week gap, defect had healed, but inferior limbal perilimbal vascularization has increased. For this, we gave mild steroids in tapering dose. His lubrication was reduced to 2 hourly. His reports were positive for SSA, SSB. Hence, he was sent to our physician, who is fortunately rheumatologist too. Post investigations, he turned out to be a primary Sjogren. Before I go ahead with further management, let's revise it first. Sjogren's syndrome is a broad category of autoimmune diseases which involve exocrine glands. Hence, all the major mucosal surfaces of body are involved. Eye and mouth are the most prominent among these. If the disease is limited to exocrine glands only, it's labeled as primary Sjogren, as it was in our patient. When it is associated with systemic diseases like SLE, RA, sarcoidosis, or organ-specific diseases like thyroiditis or biliary cirrhosis, it's labeled as associated or secondary Sjogren. There are many classification systems for primary Sjogren. I won't go into details. For diagnosing primary Sjogren, 4 or more than that should be fulfilled and criteria number 4 or 6 is mandatory. In my case, criteria number 1, 2, 3 and 6 were positive. In our patient, oral pilocar was suggested as it helps in salivation. However, this does not help in ocular lubrication. In his previous visit, we had reduced lubrication to 2 hourly and this resulted in increased SPKs. Hence, lubricants were again increased to 1 hourly dose. Considering his need for frequent lubrication, punctal occlusion was advised. but unfortunately we lost him to follow-up. Such patients actually need long-term follow-up not only with ophthalmologist but rheumatologist too. They can develop problems in literally every body organ, and they have very high chances of malignancies, particularly lymphomas. Yearly checkup is usually enough if symptoms are restricted to Sika features only. Many are kept on HCQ depending upon physician discretion. Our patient was young male, but otherwise primary Sjogren is much more common in middle-aged females, and diagnosis is usually late, as these are just considered senile dry eye. We don't ask about oral Sika symptoms routinely, and patients also many times don't reveal the systemic diseases. Recently, I had another young female who had persistent irritation for last 2 years. Initially, she was being treated as allergic conjunctivitis, but now she had developed lots of SPKs. Her right eye had diffuse SPKs and filaments. Other eye also had similar picture. In all patients with filaments and SPKs, we suspect dry eye, so we did Schirmer, and to our surprise, it was 0 in both eyes. Our next question was dry mouth, and she responded positively to that too. There was history of dry mouth. She could not afford expensive tests of SSB, so we just got the physical examination and ANA done so that at least grossly we can rule out secondary Sjogren. But clinically she fitted into a primary Sjogren category. We went ahead with permanent punctal occlusion with cautery. This helped in improving ocular surface. Though ocular surface was not back to normal, but it was better. Let's see another case where we had some other interesting findings. This 60-year male was referred by my colleague. For last 10 years he was treating his dry eye and recurrent epithelial defects with lubricants and intermittent mild steroids. His condition was deteriorating gradually, and now for last 20 days he was unable to even drive. On examination, both eyes had only counting finger vision at 1 meter and diffuse congestion. Both eyes had meibomitis and superior pannus, more in left eye in comparison to right eye. To me, it appeared epitheliopathy post-trachoma, but his left eye had 0 Schirmer, and he gave history of dry mouth too. So I suggested again certain blood tests. After 5 days, he became more symptomatic. He had developed 3 patches of epithelial defect in multiple foci or peripheral infiltrates in the right eye. In left eye, he had huge epithelial defect and mild peripheral infiltrates. So the presence of multiple infiltrates made us suspect some systemic immune pathology. When we referred him to our rheumatologist for systemic workup, then he told us that he was under treatment at PGI few years back and he wanted to consult there first. On his next visit, he brought these records. According to these records, he was a known case of primary Sjogren and on HCQ for his arthralgias, but now he had stopped taking HCQ. Though systemic treatment does not alter ocular features, but at least proper diagnosis is helpful. This patient was counseled to increase lubrication and mild steroids were given for immune infiltrates. So all dry eye patients, particularly those with conjunctival and corneal staining, should be asked about oral dryness too, as this feature of oral dryness is present in more than 95% of primary Sjogren patients. And as we know that dry eye is severe in these cases, so we should offer modalities like punctal occlusion early. All these patients should be under physician, preferably a rheumatologist. We are very lucky that we have a in-house physician cum rheumatologist, and I am very thankful to him. It's only because of him that we are able to take care of these patients. Thanks.